Hello? Hello, madam. Am I audible to you? Dear participants, we will be starting the session within another 15 minutes. Kindly be online. Within 5 minutes, we will be starting the session. Good afternoon, everyone.
Good afternoon, ma'am.
Greetings from Enepoya Nursing College.
Good afternoon.
On behalf of Department of OBG Nursing, I, Ms. Vinita, extend a hearty welcome to all the participants to this webinar on ethical dilemmas and challenges faced by nurse in obstetrics. Before we could start, I request all the participants to mute your microphones and switch off the video. Queries can be raised in the chat box or at the end of the session. You can unmute your mics and ask questions directly. Feedback link will be shared in the chat box at the end of the session. Feedback is mandatory receive a certificate. Now, I request Mrs. Janet, Academic Vice Principal, to introduce.
Good afternoon, everyone. It is my pleasure to introduce the resource person of the day, Dr. Savitha Camilda Coutinho. She has completed her BSc Nursing from Father Muller's and MSc Nursing in OBG Nursing in the year 2002. And completed her PhD degree from Enepoya University. Has lot of achievements at her credit. Presented her papers at national and internationally and published more than 12 papers. And recently her paper is accepted for ICM conference at Bali in 2021. Has completed special courses such as lactation consultant, research and statistics, yoga in pregnancy. So very committed and dynamic personality, which is evident in her profile. I stay at work and you stay at home. So thank you, Dr. Savitha, for accepting our invitation to be the resource person. Thank you. Over to you, Vinita.
Hello? Madam, are you there, ma'am? Madam, your slide is not visible, ma'am. Yes, madam. Hello? Savita, madam? Hello? Hello, madam. Am I audible to you? Hello, madam. Can you unmute, ma'am? It's in mute mode, ma'am. Yes, madam. Am I audible to you, ma'am, now? Hello? Hello, madam. You can start your session, ma'am. Dear participant, kindly be online. Dear participants, it will take another 5 minutes. Kindly bear with us. Hello, madam, am I audible to you? Madam, are you there?
Hello.
Yes, madam. Yes, madam.
Yes.
Yes,
Ma'am,
madam.
my name is registered for my son Lakshya Kumar. He's taking class, school class. So I am taking a class. Hello. Hello.
Hello. Yes, madam.
Ma'am, my name is Pragya. Hello.
Hello, Savita madam. Hello, madam, am I audible to you now? Hello? Yes, ma'am. Slide is not visible, ma'am. Can you share your slide, ma'am? Yes, ma'am. Your slide is visible, ma'am. Hello? Hello, madam? Ma'am, your slide is visible now. Hello? Hello, madam?
Can you hear she's asking?
No, ma'am. You are not audible, ma'am. Madam, your slides are not visible.
Savita ma'am, hope I am audible. Better you just use your earphone or headphone, ma'am, if you have, please. I think there is some problem must be there in the laptop. Better you just use your earphone or headphone, ma'am. Savita ma'am, now your slide is visible, but we could not get you. Ma'am, some mic problem in your laptop. Better you just use headphone or earphone, ma'am. Ma'am, Savita ma'am, hope you are getting me. If your laptop having any microphone issue, better you just come through your mobile phone, ma'am. Slide share, you can do it with your laptop. Ma'am, are you using now earphone? Or else you just message us, ma'am. In the chat box, no, better please message us.
Savita ma'am, now your slides is very much visible, ma'am. Dear all, please kindly bear with us due to some technical issues. The resource persons could not be able to join with us. Hope you all understand this problem. Sorry for inconvenience. Participants, am I audible? So mobile we could connect.
Hello. Hello. San. You are not audible. Is she audible? Somebody listen. Because I'm speaking on the mobile. People. Tell me now, anybody audible? You just speak hello. She's asking, am I audible? Huh? No.
Hello.
Yes. She's asking me to speak hello.
Hello.
She's asking, is she audible? No. Nobody is able to hear. Yeah, okay. Last week try. Which one? What is the sound?
Hello? Can you hear me? Hello?
Yes, ma'am. Yes, ma'am. I can hear you.
See, because I'm logged in into the mobile.
Yes, ma'am. You are clearly audible now.
Okay, so I'll share the PPT through
Yes.
this one and I'll talk through mobile because I logged in, downloaded Microsoft Team and
Okay, madam.
I'm speaking through that now.
Yes, yes. Now you are very clearly audible, ma'am.
I'm saying whether I'm audible. My mobile, my both are on now. My
Okay.
this one as well, and the laptop and the mobile. Where am I audible?
So in your mobile only, I think you are audible,
Audible,
ma'am.
ma'am. Okay, so is not echoing, right?
No, ma'am.
Okay, so I'll start my session. Okay.
But your slide
Because
is not visible, ma'am.
okay, I will go for a slideshow. When I go for a slideshow, only it is visible for you all. Okay.
Yes, yes, ma'am.
Is it visible now?
No, ma'am.
Not visible, is it?
Yes, ma'am. Your slide is not visible, ma'am.
Okay.
Share to the slide.
Is it visible now? I can't get the share option there because I'm in the mobile. Maybe I'm not sure. Is it visible now? I can't get the share option there
No, ma'am.
because I'm in the
Slides are
mobile.
not
Maybe I'm not
visible,
sure.
ma'am.
Is it visible now? I can't get the share option there.
No, ma'am. Slides are not visible, ma'am.
Visible, ma'am.
Okay, because I'm not sharing through mobile. I'm sharing through. Okay, because I'm not sharing through mobile. I'm sharing through.
Ma'am, can you share your slides through laptop?
That's what I'm doing.
Yes, ma'am. Okay. Ma'am, if you are still finding any difficulties in sharing the slides, you can share your slides later so that we can share it with the participants. Now you can start the session, ma'am. Yes, ma'am, your
Yeah.
slides are
Can you?
visible now. Your slides are very well visible, ma'am.
Okay. So can I start the session,
Yes,
please?
ma'am. Sure, ma'am. You can start, ma'am.
And I'm audible, right?
Yes, yes.
Okay. So sorry for the delay, to be honestly. It's all the technical problems. That's okay. We can adjust with that. So we're actually in a very hot topic, that's ethical dilemmas and challenges faced by nurse midwife in obstetrics. So as we all know, ethical dilemmas are very common and we see them in our daily practice. As we had a hard sessions, like we were trying for a long time not to get into the connections. So, and actually I wanted, normally I have done the webinar before and I could see the audience and I can see myself where I can share and interact, face to face, and which would have been really more effective. But maybe with the Microsoft team, it is not possible. But anyways, I'll try to do my best. And in case if you can't hear me, please ping me or message me so that otherwise I wouldn't be knowing whether you can hear me or not. Is it okay?
Yes, ma'am. Yes, ma'am.
Okay. So any of the audience, I think there are many audience as well, those who are listening to me. In case if you can't hear me, please message to the main links or the Microsoft team organizers. Otherwise the session will be off if I don't if you can't hear me. Okay, you can send the messages onto the Microsoft team. Okay, so let's go into the topic actually. And as I say, ethical dilemmas are very common in our practice. As we say, we clients and the healthcare providers differ in our understanding whether we are right, whether we are wrong. Ethical dilemma arise every day. Now I'm practicing, like I worked as a teacher. I'm working as a midwife at the bedside nurse. So I come across more than as a teacher and educator. I come across when I was providing the care at the bedside in my clinical practice, a lot of dilemmas come, and you face a lot of dilemmas and you do not know whether it is right or wrong. But if I'm following the policies, if I'm following the guidelines, if I'm following the protocol, I know that I'm doing right. So, but in maternity, we are advocacy for a mother and we are advocating the baby as well. So we are dealing with the two people in here. So as I say, healthcare providers differ in their understanding what is right and what is wrong. Ethical dilemmas might arise and it may be in everyday practice, and healthcare providers we have the responsibility to analyze these dilemmas. And as we all know, the ICM code, International Confederation of Midwife, we have certain codes and it mainly says that making a decision which is relating to the women, families, policy makers, or to the other healthcare professionals, the main code is safety here. We always see in our practice, right of the women, safety of the woman, which is very, very important. And I have listed here, I thought if there are MSc students here, there are a lot of legal issues. I've just listed them. As I'm sharing the PPT, the students can go through it. I'm not going to explain these legal issues now. You will find in the books, you'll find in the journals, and you will find in the publications. So which have taken most of them, including in India and abroad, and listed them all. So I'm not going to waste the time. Like there is a one here, legal issues like a problems of medications, which we come across every time.
Hello, madam. Sorry to interrupt you, ma'am.
Yeah.
Can you mute your laptop, ma'am? It is echoing, ma'am.
That's what I thought. Okay.
Yes, yes.
That means you can hear through my mobile laptop now, I guess.
Yes.
Okay. Is it okay now?
But your slide is not visible, ma'am, now.
Yeah, that's what happens. The moment. Okay. One second. I don't want to disconnect to the mobile because it.
Okay.
Is it voice is echoing? Is it?
Now it is not echoing, ma'am, but your slide is not visible.
Okay.
Echoing.
One sec. Can you see it now?
No, ma'am. You just click in that PowerPoint, ma'am.
I did that.
Yes. Your slide is not visible.
Yeah, it automatically goes unsharing that tree. Can you see that now?
It's echoing, ma'am, but your slide is not visible.
Yeah, the moment I do in that, it is echoing. One second. It's not giving me the share option now.
I think you can start the session, ma'am. Later on, we will share your slides to the participants' email.
Can you share my slides, please? Can you share my slides, please?
Okay, madam. You email us, ma'am. We will do it.
I have done already to Janet.
Okay, ma'am. Okay. Ma'am, you can continue the session. Meanwhile, we will share the slides.
Hello? Can you hear me? Can you hear me?
No.
Yes, ma'am. Yes, ma'am. We can hear you.
Yes, ma'am. Yes, ma'am. We can hear you. Yes, ma'am. Yes, ma'am. We can hear you. Yes, ma'am. Yes, ma'am. We can hear you.
Can can you see the slides?
No.
Ma'am, your PPT is visible, ma'am.
But my sound is echoing, is it?
Yes, ma'am. We can hear you.
Is my sound echoing?
Yeah, ma'am.
Yeah, I think because I'm logged in laptop and I'm logged in the mobile as well.
Yeah,
So I have.
PPT we will share, ma'am. You please just continue from your laptop.
Shall I yeah?
Yes, ma'am. From your laptop, you can discontinue and continue with your mobile phone.
Okay. Can you hear me now? Hello?
Yes, ma'am. Yes, ma'am.
Now the echo sound is gone, yeah?
Yeah, ma'am.
Okay. Can you are you sharing my PPT?
Yes, ma'am. We will share it. You please continue, ma'am.
Okay. Hello? Hello? Can you hear me? Can the
Yes,
audience hear
Savita, ma'am.
me?
Please, you can continue, ma'am.
No, I just want to know, can you hear me?
Yes, ma'am. Yes, ma'am. We can hear you very well, Savita, ma'am.
Ah, you can. Okay. Can you see my PPT? Because I'm in the blind section because I do not know whether I can
Sure,
hear
ma'am.
you.
You just continue your talk, ma'am. Savita, ma'am. Meanwhile, no, we will be making arrangement to share our PPT.
All right. All
You
right.
just
All
continue,
right.
ma'am.
Okay.
We'll take care of you, ma'am. Please, no tension, nothing, ma'am. Please, you carry on.
No problem at all. Okay, that's
Okay,
fine.
ma'am. Thank you.
If the
Okay.
okay, so as I was saying, like as I said, I give the introduction and I shared the PPTs on for the students. I said what are the legal issues we can face when we are practicing. So I'll read it as you can't see the PPT. The medication, there could be a problems, failure in adequate client monitoring, failure to adequate assess the client, failure to report changes in the client. Abortion is, though it is not in our country, could be a legal issue, but in other countries, abortion could be a legal issue, though in our land now the abortion is legalized. And ethical principles, as we all know, ethical principles, we have beneficence, autonomy, non-malfeasance, justice, and confidentiality. Now, I actually have a pictures on my laptop we're sharing, which I cannot share with you now there. So I have a picture here, like if you get a PPT, you can watch and say, it says, we are new at this. What do we soon now? That means people can come at the counter in the reception and ask, because there are a lot of changes now, and if we have not informed them the changes are happened and changes have taken place, like example in the COVID period, now we have made a lot of changes regarding the visits, same in India as well, and they are missing a lot of informations as well, like could be a support from the breastfeeding, could be for the scanning, could be for the referral for the thyroid, could be for the diabetic, clinic appointments, many antenatal visits, many, or if they wanted to, talk to the midwife, they could be missing many things. So they can say that we have not received the care what we according to our expectations. So they can, if there are some changes we have made and we have not communicated to them, they can say that yes, they can ask, we were not aware of them and we have not received the care what up to our expectations can we so now. So As I said, midwifery is a profession discipline which combines the science, art, and strong ethical values. That word is very important in our midwifery. Though it combines the science, art, plus it has a strong ethical values. If you're in a practice, if you are in the midwife, you're working, those are working in the OBG wards or maternity wards, you always come across all these legal issues and the ethical values. As we said, we do not know what is good, what is not good, what is right, what is wrong. Okay, so ethics seeks to always resolve the questions of human morality, like such as good and evil, right and wrong, virtue or vice, justice and crime. So ethical dilemmas in nursing is often based on nurses' commitment to advocacy, and also, as I said, we advocate for the two individuals, to the women and to the fetus. So ethical dilemmas refers to when there's a difficulty in deciding which action takes precedence over the other. The dilemma has been described in a situation describing choices between appears equally to be desirable, undesirable alternatives, or it can also be described as a situation in which the patient's rights and the professional obligations can conflict. Now, I'm just going to talk about the practical, which I come across, which you come across, and I think if possible, the audience can also share which dilemma I will share in my practical experience, what ethical dilemmas I came across and what you have come across, so we know altogether what is a common in our country and in here as well. So normally I feel the patients will have these 5 questions whenever they come, or if they have a bad obstetrical history before, they always come these 5 questions in their mind. If something has happened before, I'll give an example. I had a woman last week whom I've taken care of, and she had a forceps delivery in her first and had a neonatal death after that. And then she had her second baby born at 36 weeks, and her third baby was born at 37 weeks. And they had to go to the neonatal NICU after that. So, but both the mother and father had a trauma of having a forceps delivery. She dilated but could not deliver, had in forceps, and thereafter a neonatal death. But that trauma is very strong in their mind, and they had a fear. So that first question was in her mind: what was the problem? Why did it happen to my baby? And what was the problem? Because I fully dilated, and then I had the term baby. Like she was 30, I think she was a preterm as well, sorry. But, she could dilate it. Forceps delivery did happen. They did the forceps, but why did the baby, the baby had a problems and had a neonatal death. So why did it happen? Why did it happen to me? Like always the women will ask, if that has happened, why did it happen to me? What did you do about it? What, as a healthcare personnel, when she comes to an antenatal history, we have all this history, the history taking, one who meets first the midwife, or I know in our country the doctors takes the history, we don't take it, but there are places in our country where the midwife practice in some of the places and take a history as well. So when in the history, it is very, very important how much of her past we have taken. Is she allergic to drugs? Have we taken that history? Did she had any bad experience in the previous? Did she have any psychological problems? Was she diabetic, or did she have thyroid problems, or any other problems? Or in her previous deliveries, did she have any of the stages of the labor? Did she have any problems? Or during the pregnancy, did she have any blood pressure problems? Was there any changes in this pregnancy part? So the history collection is very, very important, where we found here in Ireland, the midwife takes all the histories and write it, and then she will collaterally refer to the different departments according to the need of the women. Say if she had a bad breastfeeding in the previous experience, she will tell that I had and I couldn't successfully breastfeed. Then they refer to the lactation consultant antenatally, and they can sort it out in this pregnancy. So if they had after delivery, if the baby had a problems or could not breastfeed or any tongue ties or any other problems baby had or went to NICU, jaundice problems, still the antenatal history time, if that was a worry, they will highlight it or they'll flag it. And then in this pregnancy, in the second pregnancy, when they come, they will refer, and see that we try to avoid not to happen, that the women doesn't go through that. We'll try our level best. So my woman, the same, this question, she had it, and I'm going to say how we solved it. Yes, she had a problem, which we did. It was in her flag history. And when I was taking care of her woman, I was told when she came in labor to me, she wasn't in labor. She came from the antenatal ward. We call it as a prenatal ward in here in my hospital where I was. And she was brought in because she had a previous, she gave the history saying that I was ARM'd, that is artificial rupture of membrane, and within no time, I couldn't get an epidural. Here, most of the people ask for an epidural for a pain relief, and I couldn't get it because my baby was born. But this time, I don't want to have it because as soon as you ARM me, I'm going to have a baby. And we did consider that. And from antenatal ward, we did not normally the ARMs, induction. Either you go for, as we go for inductions, either the prostate inductions, here they call it as a profes, the prostaglandin, they put it as a tampon, which I do not know, we still have it back home in India, that one, but we do that in here. They put a profes for 24 hours, and then after that, they give the prostate gel, like Serviprim back home or in India. In Fadmulas, I know we give a Serviprim, and then after that 6 hours, then you do an ARM after that. That is a stepwise procedure, profes, prostate, and then ARM. If you're still not going in pains or labor, you do an ARM. The midwives does an ARM here, or the obstetrician, but most of the midwives do an ARM. So, and then if she's in labor, then they come to the labor room. So this particular lady whom I said, which I'm referring to these 5 questions, because she gave the history that she had a quick deliveries and had a bad obstetrical history, she was straight away brought to the labor room and was asked ARM. So when she came to me, after once she started putting the CTG on and everything assessing, and I did not ask her anything because I know history. I didn't want to bring that trauma recalling to her, but I read the history very well of her. And when she settled, she wanted an epidural very badly. So, and I did ARM her and then we went for an epidural as well. But her waters I couldn't ARM because her waters were already gone. I couldn't feel any bag of membranes. I did explain to her, but they were kind of more worried because if you do ARM, I'll deliver. But she took nearly 2 hours and she delivered the baby. But when she delivered baby, when I delivered that baby, it had 2 cords around her neck, nuchal cords. And the dad was so worried, recalling his first baby's birth experience. He did ask to me, because is that a worry? And they were so worried looking at that cord, but it was it was loose. I can loosen it, and baby was all fine. This was 36 weeks, 6 days baby, and it was all fine. Normally delivered, no problem. It took such a long time for them, to make sure to enjoy baby, recalling the past. So as I said, what did we do? What did it happen to me? Again, she had that question. We avoided that, bringing to her from antenatal to the delivery ward, doing an ARM, and then giving an epidural and delivering her baby safely. What did you do about it? Yes, we brought her and we saw all the safety and the women's worry. And will it happen again? No, it did not. So this is how the ethical dilemmas, what I'm saying, in case if you're gone through as per the protocol, ARM in the prenatal, and if you're not taking care of it, if you didn't know her history, and if you did not know about her worries and anxieties, she would have, if you ARM in the antenatal, she would have delivered. If the baby had any problems, again, there would have been an ethical issue. So this is how most of the women coming to us will have this question if they had a bad obstetrical history, and it is up to us how accountable we are and how much we are respecting the autonomy as well. All this comes in here and beneficence. Can you all hear me? Yeah? Hello?
Yes, ma'am.
Hello?
Yes, ma'am.
You're
Jennifer
all
can
there.
hear.
Okay. Okay. I just feel that I'm only speaking and I do not know whether you all can hear me. Okay,
Yes.
that's fine. Yeah. And just certain clinical examples I have here for perinatal ethical dilemmas. This is again from the journals. I have taken it for you all, but later I'll be sharing actually what is my personal experience. The court ordered treatment, withdrawal for life support. These are all the ethical issues. And again, harvesting the fetal organs or tissues, in vitro fertilization, fetal surgeries, treatment for genetic disorders, equal access to prenatal care, maternal rights versus fetal rights, extraordinary medical treatment for pregnancy complications, using organs for anencephaly infant, genetic engineering, cloning, surrogacy. All these are kind of theoretical, which all has each one. These are for ethical examples for ethical dilemmas. But we are not, as a midwives, we are not coming into most of them. Some of them, yes. Most, like in a practical situation, yes, but not all of them. So whichever I can, because ethical dilemmas to speak, you legal issues, legal aspects, you need a nearly 8 hours, 10 hours session. So it is not a small topic. It's a huge topic where you discuss a lot of things involved in this, mainly the consent, the autonomy, the incidents, and then communication, team working, problem major solving, all those. Like, you can talk to you need a solicitors for this and all this to speak about, because they are the one who solve this when it comes to ethicals, all this. So I'm just going to tell you, when we are in practical, what I have faced and what you would face normally when we are at the bedside caring of the women. So now, these main ethical issues which I could see in here, which in my practical experience, which I could come across, are cerebral palsy, shoulder dystocia, which is very common, 3rd and 4th degree tears, perineal tears. We otherwise call them as OASIS, if you know. Stillbirth or unexpected neonatal death. I gave already in one example for you in my clinical. Retained products or swaps. Maternal postpartum hemorrhage, very common. I've come across so many PPH problems if you're not acting tactfully. And I have also experienced back home as well with the PPH. If we do not have a protocols as such for the, I'm not saying in all over India we do not have, but I don't think we have a PPH protocol, whereas in here protocol, you know what to do if you have a PPH. What you have, you don't need an obstetrician help immediately. But yes, if you have 1,000 liter above, but you just know what to do stepwise. There is a protocol and you just know it, and you will be doing it automatically, involving the team, anesthetists, the obstetricians and everything. Whereas I don't think we midwives know it, but I'm gonna tell you as well how we manage. And then facial lacerations during cesarean section, which we faced back home as well, I have come across, and that's again an ethical issue where we don't much involve. It is not under our scope because we are not doing the cesarean section. Then bowel perforation during cesarean section. Normal claims for the ethical issues arise in our care. Provision of improper, inadequate care. If the woman has not received during antenatal, maybe during her visits, antenatal, intranatal, or postnatal. If she doesn't receive a proper care, and if I'm not satisfied with this, I'm just going to give you an example. I've come across this recently. I had a woman who was, gravity to para 1, and she came from she was a gestational diabetes woman, and then she came across to us. Actually, she was in labor, but antenatal wards were really busy. The midwives are actually really busy. They examined her. She was using Antonex. Everybody knows, I think most in India we have the Antonex. We use them during the labor pains, and she was using that one. And then when she came to labor, and she was just asked, I want an epidural. In Ireland, it's very common. People ask for an epidural. And others here, they just epidural. Antenatally, they take a pathogen, and then they come Antonex, and then ask for an epidural. I just put the baby, I just did the abdominal as my routine, do the abdominal palpation, did the abdominal palpation, and started the CTG because she was a GDM as well, gestation diabetes on medications, not on diet either, not on insulin, just on medication. And then I just trying to locate the fetal heart. I couldn't get the fetal heart. And I called the CNM2, clinical manager 2, saying that I'm unable to locate the fetal heart. If she could look it, because she was a huge with the high BMI lady. And I was trying to do that and I couldn't get it. She was just asking, give me an epidural. But before we give an epidural, my ethics says I have to see the baby is safe. Babies, that I could do, even though I have to locate first the fetal heart rate, and I have to start monitoring the CTG. And if the 20 minutes trace is fine, then I can give her, we can organize for epidural. That is what the hospital protocol says, and that's what my ethics says, following the policies of the hospital. She was continuously asking for an epidural, and I couldn't locate the fetal heart rate, and I had to call the CNM2, and she couldn't because of the high BMI. And I just put the clip on. We do here, on the fetal skull, we just put a clip on the baby's head, and you can monitor, and the sound will be very different. So I just applied the fetal skull electrode. We call FSC for that. So applied, and I could locate it. And then by the time I did an examination, when she came from the antenatal ward, she was 5 centimeter dilated. By the time I examined her, she was 8 centimeter dilated, because to put and apply an FSC, I have to examine her. And when I did that, she was 8 centimeter dilated, and she was ready to have a baby. And there was no point at that stage. If you're a second mom, everybody knows, we know, for the first baby it takes 8 to 12 hours, whereas in the second baby, the half of the hours, if you're 8, within no time you can deliver a baby. So I started the CTG, and then anyway, within 15 minutes altogether interval, she delivered a baby, normal, healthy baby. There was no problem. But she went to the postnatal and everything. But she reported saying that she did not receive an epidural. She wanted an epidural. She did not receive an epidural. She did report to the hospital saying that she wanted an epidural. The midwife did not give me an epidural. So I was called asking by him, why didn't she get an epidural? And we went through the records. She was not even 10 minutes. The epidural will take nearly 20 minutes to site, but she was not even 15 minutes in labor room. She had a baby. You see? So sometimes the people can claim that they might perceive that you have not received adequate care, but as per the ethics, you cannot, because the babies, you have to monitor the baby. You have to look at the baby's fetal heart rate. So you do what is right for the baby and mom. But again, you failed to organize an epidural for her. So it is again an ethical, dilemma for you. Would you organize, because women ask an epidural, which is unsafe for her, where I can not see whether the baby is fine or not. So this is the example I gave. So like this, you come across a lot. Failure to protect the mother and her baby from the risk of foreseeable harm. Yes, when we do in a practical experience, and it could be antenatal as well, as we come across a gestation diabetes mother, or if mom with the drug abuse, we don't find that back home as much. If they have a previous history of PIH, the pregnancy-induced hypertension. So with all this, if you know if you have PH, what we have to do in the next. If you had a history of PPH before, how can we avoid PPH this time? What are the precautions we can take? So all these need to be known, and if you're not taken care of, it becomes again a legal issues, or it will be ethical dilemma for us. Failure to consult with more experienced medical professionals. Yes. See, we come across the women in labor room as well. As I worked in fatherless, I know our own nurses, midwives take care of the women in the ward. And if you have any problems, like I always request, call. Even though we are seniors, even though we are experienced, still always second opinion matters a lot, especially in the maternity, because you're taking care of the two people, the mother and the fetus. You always call for obstetrician or whoever I think back home we have an the PGs they are there all the time in the labor room. If not, sometime if she is unable to take a proper decision, and if you are an experienced midwife, you have worked there in the labor room for long, you know what is to be done right. Always go ahead, take a step ahead, because that will help the baby and mom as well. You can prevent something going wrong. So I have come across, like, I'm going to, I think in Melissa, it had happened where I worked in one of the hospitals. There was an IUD, and the people blamed, saying that it is the nurse's problem. It had happened, the nurses did not take care of it, but it wasn't. We do not know. They put the CTG. CTG was on. CTG was fine, no problem. She was in a labor, in the labor room, and there was an IUD. So we do not know what was the cause either. And it was a private patient. Then the consultant came, and they did not blame the consultant. They blamed the nurses. I remember here they blame typically the nurses, and I was involved in this. And then I had to speak to the parents and everything, and tell them it is not the problem of the nurses. But you see how much we were lacking the documentation. We need to have a documentations, what we have done, how many times we have listened to the fetal heart rate when they are under our custody. We know, as in the Venlock or litigations or anything, we just don't monitor them. I know our people are not much for the claims, or they are not aware of this, but it doesn't happen in the Western countries. People are well aware what is it, and policies are in place. I think wherever we are practicing, it doesn't matter which country. I feel our ethics says proper monitoring and documentation, which are very, very important. You monitor. We know in labor we have to monitor in every 15 minutes if they're in the second stage. If not, we monitor, listen to the fetal heart rate here every 15 minutes. So if the woman is in the labor room, I think it is accountability for our midwives, our nurses, to record the fetal heart rate, to record every event the mother has done. And if you have any doubts, call the consultant, call the doctor, and record that as well. What time you have called, what time the women, how many contractions the women had, and was she able to cope, and what was the fetal heart rate, what are the events. I think sometimes there could be a language barrier for us, but still record. You need not have a good language. With the good medical terms, the few words are also fine, but record everything and monitor the women. That is very, very important, which is then we are following the policies and we are within our ethics. So I think that time ethical dilemma should not occur unless the problems can occur in the first stage of labor, second stage, or third stage. You would never know when the problems come. But recording and monitoring is very, very important. So failure to consult, that's why I said, if you have any problems, if you think if the CTG showed some decelerations, either could be early or late, if you think there is something wrong, you could hear, I know we use the PNAD back home, but if you have a doubt, use the Doppler. I know sometimes the lack of resources could, again, a biggest ethical dilemma for us. All the resources are not available in every hospital for us. But still, with the available resources, what we have, if we do our duty and if we record, I think we shouldn't be any problems. Unless the problems, as I said, they will not say and come, they just arrive on time. See, postpartum hemorrhage can happen. I had a lady who did not take an epidural. She was just using the gas and that is Antonex. Delivered, prime up. She wanted to have, without epidural. Everything happened natural. She membranes ruptured on its own. I did not break them at all. She wanted it that way. And then she had a baby, normal delivery, SVD. And then immediately after delivering the placenta, we delivered placenta, and she started bleeding. So, which is not in her, she's the first mom, so there shouldn't be any history. Which I did not expect it at all that she would have in PPH, because the membranes, the placenta was complete, All membranes came out. There was nothing, but still she went for a PPH. But she did not go for a major PPH more than 1,000. Hers was around 800, which still again she had, which I never expected to have it. So that's why I said anytime you wouldn't know how uterus reacts and when things go wrong, but we need to be ready all the time to face the problem. So the women ask a couple of questions. Why did I bleed? What happened to me? When we give a second dose of oxytocin, we follow the protocol, take the bloods, do an HP, do a group and save, catheterize the woman, ask for the protocol of the PPH. You follow, she receives the. She did not have a cannula either when she came in because she said everything went normal. I did not have to start any fluids for her. But because in the third stage, the end of because she started bleeding, I had to start the fluids for her inside the cannula, everything. So sometimes they can ask question, everything went normal, now what happened? Why did this happen? So that's why I said we always need to be ready. And if you have any problems, I have to call the obstetrician to say review her, and they came in as well, and we all three of us, the midwife, CNM 2, I was a midwife, and then CNM 2 and the obstetrician to manage the PPH, 3 of them, and it was okay, and it resolved, and she transferred to the ward, and she was happy. Then I went to see her next day. She was all happy. So, but this is what I said. Just we need to, if we have any doubts, always consult and get the opinions. Failure to refer to other medical profession when complications arise. Yes, if you think if woman needs reference to be done, like if you have a DVT, or if they have an allergic reactions, if they have problem from the epidural, or if they have any cardiac problems, clotting problems, all these they will be referring to the different departments according to their need. And if they have any psychological problems, again you have a medical social worker involved as well. So we need to refer to the different medical professions according to the need of the women. Medication errors, yes, as I said, if we are tend to antenatally when they come in, when the booking, we need to take the history. Are they allergic to any drugs? Sometimes we might do as a midwives or nurses, we might do drug error. As we know, what are SALEPs? I think those who are NABH hospitals all know this. Like there is oxytocin, otherwise it is called as syntocinon. Also there's a symptometrin. So these are two always can be, we say them same and they look alike as well. So look alike, sound alike drugs. Look alike, sound alike posters. Okay, they are called SALEPs. So you have all this. So we need to be very, very careful. Always read them, read the dose, always counter check them. We don't have that in India. We don't have 2 people checking and signing. We don't have, I think when I was in Father Muller's, I did in the postnatal ward, anti-labor ward, I always said that always when you check in the medication, check 2 people and then sign it. You have to check always with the other person, especially the maternity drugs. Please do check with the other drugs, with somebody else for their expiry date, for their content, the dose, and sign it how much. If you're given 10 units, just because oxytocin can be injudiciously administered and so we need to be very, very careful when we're giving in intranatal or antenatal any medications to the women. Even if you give a labetalol, like we give Antanol, I don't know what we call back home, I forgot that now. So when we give the antihypertensive drugs, if the woman is pregnancy due to hypertension, record it. I know we need not record, but I always check. Please check with another nurse or midwife and get it signed, double check, sign. You're always safe that you're given the prescribed dose for the women. So medication error is always a common problem as well. Again, the route, if you're supposed to give IM, you give IV. If you're giving IM, you give IV. Sometimes that can be missed from us as well. So always read. And always before giving the medication, again, my request, I know because I worked for long back in India, so I know we never call the women with the medication, their name and the hospital number. Each woman has the hospital number. We all know that. So it's always better when you give a medication to avoid a medication ever. Call. There could be two B Fatimas. I remember the incident Auntie happened in the back home, given to one, instead of giving to one of the B Fatima, it was given to another B Fatima. So this can happen. So always call their name. Names could be, similar. So always read out their hospital number. I think we have now ID bands, is it? I think so. We have, most of the hospitals will have their name bands, don't they? Wristband. Yeah. Can you hear me?
Yes, ma'am.
Yeah. Okay. So
Savita,
most,
ma'am.
yeah. So
could you
if
please
you,
tell us which slide you are in? If you say the slides, accordingly we could able to adjust, ma'am.
I'm in the slide number 15.
15. Okay, ma'am. Thank you so much. Thank you, ma'am.
Okay.
You carry on. Please, ma'am. Yes, ma'am. Thank you. You carry on.
Okay. So you have an ID band. So just check with the ID bands whether the name, the hospital number, and their date of birth as well. These are very important. Like these three, if they are similar, they cannot go wrong. Hospital number is very unique ID. We know that. I think the hospitals which have gone NABH, that was a very important unique ID number of the patients. So name, hospital number. Ask the woman. You don't say it. Ask the woman what is, say your name and date of birth. She will say it, and you read out the number, hospital number, and see whether it's in the wristband or in her chart which is belonging, which makes you to confirm you're giving to the right patients, which is very, very important, where we can have problems. And if it is a medical error, it is an ethical issue and a legal issue. So that, and check the dose, check for expiry. These are my requests for all the nurses and midwives over there. I know what is practiced back home. So always in your practice, include this as a best practice when you give the medication. Don't forget it. Ask their names, date of birth, check their hospital numbers, bring the chart over to the bedside. I know all the charts are kept at the counters, in our nurses' counters. Bring to the bedside and ask them. And then you always make this habit as well. Ask, do you have any allergies? Though it is not a, we don't have in our, normally we don't have a drug chart. I know NABH hospitals have, some of them have it. Even the simple, what doesn't matter, you don't need to have a fancy drug chart. The simple drug chart, always ask on the top, do you have any drug allergies? And I think in our admission notes, always should go, does the woman has any drug allergies? And if she has, even though it is recorded, just in particular, again, ask to woman, do you have any allergies? It could be for the food, could be for the drugs, dust, or whatever. Do you have any allergies? So, which is very, very important, because they might get an anaphylactic shock, and then. So that's how medication errors occur very often, and maternity is very common as well. So just to be careful about it, because it is a major legal issue. And these are the legal claims. Well, I've written here legal claims, why it can happen. And these legal claims are the ethical dilemmas and ethical issues that can happen for us. So inadequate record keeping of observations, caregiver, and medication administrator. Yes, we need to keep it. I know sometimes we are very, very busy. We are unable to do it. Or sometimes we have short staff or more of patients assigned. Or sometimes we may not have the proper system of recording, but we all have a nurse's record in every hospital. So just record. I know in here we have a protocol, we follow it. Sometime in my practice, I've come across, though in this Western countries as well, they have a short of midwives, they have a short of nurses. Sometimes it can be too busy. And I myself sometimes feel I'm unable to give a quality care because it was too busy. But still, I have now there in the working. There is no writing. Everything is electronic. It takes a time. I felt the handwriting was much better, faster, quicker than the electronic one, because you need to go into the computer. You write everything in the, whatever you have done. You have a different sections to log in, go into, and then record, including the vital signs, including if you have a bleeding, you have a different. you need to go and enter in there. But what I am doing as well, like I'm doing my traditional method. There's a documentation section where I go on recording everything as I used to write it in the paper. You need not do, that's what they said, but I do because after working these many years, I know what it was. I attended this legal workshop as well. What is important here in Ireland, the claims are more, and they do kind of, write and sue and all those things. So keep whatever is done and whatever is informed, everything will be written in. I do write by myself just to protect me and the hospital. And recording is very important. So inadequate record keeping is most of the time. Say if the woman baby has cerebral palsy and you have not recorded they will look into the record from the time the beginning of she registered. Intranatal is very, very important. Intranatal care is very, very important in the cerebral palsy claims. So you have to record everything. They go through the CTGs. What were the contractions? How much oxytocin, if she was induction, how much oxytocin was, whether oxytocin was reduced, whether oxytocin was increased, whether number of contractions were monitored. Have you informed if she was working on everything? So it's always better to record. So if you are not recorded improperly, if you look back, that could be very difficult to, there's no supporting documents. So the legal claims people can sue. So caregiver medication, so difficulties in instrumental deliveries. Yes. Most of the time we come across to the instrumental deliveries. If there is no normal delivery. I know back home, many of women do not go for instrumental deliveries because we don't have an epidural. I think our instrumental deliveries are less, but our cesarean sections are more. If they're private patients, if they do, I think for this legal claims, they do go for cesarean section, which is the safest one. They think, the obstetrician thinks. But in here, they try maximum for normal deliveries, and people are going for instrumental because they have an epidural. You see, when they have an epidural, they can't bear, they do not know where they're pushing. They don't feel that sometimes epidural works very good for them. Sometimes it wears off. So most of the time, I won't say most of the time I have delivered the people normally. Sometimes they dilate, we push them. According to hospital policy, maternal efforts, pushing can be done only for an hour, which we don't have that again. Back home, we don't do that. We push for an hour. Here, there is no fundal. People are going for instrumental because they have an epidural. You see, when they have an epidural as well, they can't. So they push for an hour, and if the woman doesn't deliver within an hour, then obstetrician comes and he examines and then see the position of the baby and everything. And if it is, so they, based on where the station of the baby, put in either kiwi or the go for the instrumental deliveries. Now, the women come with our women normally back home, they don't say I want to unless they're educated, they kind of have the knowledge. Otherwise, they don't say I want this. They don't have a birth plans or anything. Here, the women can come with the birth plan and they will say, I don't want episiotomy. Again, that's their right, choice. We say autonomy. Again, ethical comes, beneficence and autonomy comes in there. Consent comes in there again. They don't want to have an episiotomy. They want everything. Some women come, they want only everything to be normal. Even the dad cuts the cord in here. And they'll ask to allow, for a pulsation, you need to allow not to cut the cord immediately, which we do back home. Here, we will allow them for a minute, until you stop the pulsation, as we say back home. Here, we do practice that, and then dad cuts the cord later. So all these things, if the instrumental deliveries is there, if we have to say now, if she's fully dilated and they know 1 hour. So for my ladies, I do explain to them I'm allowed only to push for an hour. And if not, then the obstetrician comes and he will if you're not able to deliver normally, there will be either kiwi or forceps will be applied. I do inform them. So sometimes it motivates them to push very harder. They do because they want only normal delivery instrument. Sometimes you have to. Again, that consent will be taken from the women for instrumental deliveries. So as I said, I've given you earlier example. I had a lady who had a baby with instrumental deliveries and there was a neonatal death. Yes, there could be, if the woman is fully sometime instrumental deliveries, if the baby is in the occipital posterior position, it is very, very hard. Sometimes it is really, really difficult. If it's a direct OP, normal delivery is very difficult, which I have come across. I've with the direct OP and I have pushed them for an hour and then I can push, as I said, we can push only for an hour. Then the instrument and I can see the baby straight away looking up and coming. It's very difficult. It could be possible for us back home because they don't have an epidural and they can, push harder, and it is since they can feel and it can be avoided, maybe instrumental deliveries. Again, if the baby is okay, as a midwife, say I'm the midwife and the woman is baby is in the occipital position and she's having an epidural and I bear down for an hour for her, and if she has still the baby, I can only see the not reach to up to the crowning. I can only see the little part of the baby's head. If she's in the +1 and I'm not able to deliver, then I call the obstetrician. But if the mom says no, I don't want an instrumental delivery at all, what would we do? Again, I can give an explanation. The obstetrician comes and I have to call my CNM2. She comes in, then calls the obstetrician. He or she comes in and they explain to as well. Now we are in ethical dilemma here. You're not able to deliver the baby normally. You're not able to push more than an hour. Okay, if you push 15 minutes more, still your baby is not, there's no sign of, head is not advancing. And what would you do? And woman says, no, I don't want, if she declines, I don't want instrumental delivery. Then sometimes they might choose an option for cesarean section. And this has happened as well. And then went to cesarean, couldn't do the force that they do a trial labor in the theater, because if they can't in the labor room, they take to the theater and do a trial labor. Tried for an instrument, it was not possible, and they had to deliver the baby by cesarean section. So here again, as a midwife, the documentations, listening to the baby's fetal heart rate until they deliver, until they do everything, even in the we go to the theater here and we listen to the fetal heart rate until the baby is born. After draping, after scrubbing, we just stay away, but we receive the baby in the theater here. We go and receive the baby in the theater. So, which is a beautiful part of it, which I liked it. You're there with the woman throughout the labor, and the women feel safer because you are there with her for 8 to 9 hours. Your presence makes a much difference for her. So, as I said, difficulties with instrumental, that could be ethical dilemmas. There are so many things involved in this. Inadequate Ctg monitoring, yes, we monitor entire indication for SVD, like if everything's spontaneous onset of labor, you don't have to put a continuous CTG. You can do every 15 minutes listening in, but otherwise you have to pin the baby meconium, like if there is a light or color change to meconium, or if she has a previous cesarean sections, PIH, if she's on oxytocin, you need to monitor the CTG continuously until they delivering, or epidural if they have. We need to monitor CTG, and we have to see the access. We every half an hour we interpret the CTG, and you write what is duration, what is the frequency, was it normal, was it suspicious, what was it pathological. Our CNM2s are monitoring centrally all the CTGs, but they come in and ask, or if they are in some other room, I must go and report to them, see, can you have a look at my CTG? The CTG is like this. There's the early recession, dangerous. So we just going to, even when we are bearing down, sometimes the baby doesn't like the pushings, then we can't go for pushing if the baby is, if there's a deceleration. So all this interpreting the CTG is very, very, if you have any variations, any doubt, always inform your senior, take a second opinion, and then record it that you have interpreted this, inform this is What is the action taken if there was a deceleration? Did you turn the left side to increase the fluids? When you have a deceleration, fine. Did you increase the fluids? Did you turn on to the left side, change the position and see? Or, did you reduce the oxytocin rate? All those things. What did you do? Or they do here, if you have recurrent deceleration, to know whether the baby is happy or not, they do the fetal blood sampling and find the pH. So whether that is done, what are their results? All this going through the claims, all this will be retrieved and asked for. So again, proper, Ctg monitoring is very, very important if you do, again, ethical issues. Consent and failure to warn the risk. If the women, we need to take, if even the fetal blood sampling, if you have to do, you have to take the women consent. See, we need to monitor. We have to little bit take the blood from your baby's head. They will be worried. Even if when you put the clip on baby's head, they will always, the woman which I said, referred earlier and given example, gestation diabetes, where I had to put the clip on baby's head. The woman asked me so many times after delivery, both mom and dad asked me the questions. Will there be a mark on the baby's head? Will that affect the baby? Because they have the knowledge of cerebral palsy, things, all those things. Will that affect the baby? Will there be any problem because you put the clip on the baby's head? So anything what you do, ask the consent. And if they say, right, women consented, explained, and this is done. Then breakdown in communication between the medical profession. Yes, that is, we need, as I said, if I'm a midwife second, if I have any doubt, report to my CM2 and say this is something, and they report. If they say and report to the obstetrician, they come. So communication and having a teamwork is very, very important in the midwifery. Allegation relating to the use of oxytocin, as I said, injurious administration of. I'll give an example again in here. Now we get the women with the I think it is very common in back home as well. We normally do oxytocin induction, and most of the women, if they're not contraction, we put them as oxytocin as an augmentation. And we do not have, Western countries are sophisticated. They have everything in there. Like women will be in one single room with the monitors, with the separate oxytocin pump, everything disposable is there. Whereas back home, I would advise a midwife, when you put an oxytocin, all our nurses are monitoring the oxytocin. Most of the women go for either oxytocin induction or augmentation. Most of them are in oxytocin, because I worked in the labor room back home. I know it. They're on oxytocin, and we go at rate 8 ml per hour. So when it is on the rate, just monitor the contractions for 15 minutes or 10 minutes whatsoever. Just monitor the contractions. Here, if you have 7 contractions, for prime can have a 7, if they are on oxytocin, a prime can have a 7 contractions and multip can have a 5 contractions when they are on oxytocin. If they are spontaneous contractions, you don't count them. If they have more, we can't stop it because it's their body. But if they are on oxytocin, just our midwives and nurses, please record for 15 minutes her contractions for 6 minutes. And if she is more than 8, more than 7, the 8 or 9, whatever the rate comes down, or inform the obstetrician, this is this, and let them know, the PGs in the labor room or the consultant in the room, just say she is doing over contracting, and can we come down on the oxytocin rate? Or so very, very important, because sometimes hyperstimulation can end up, and affect the baby as well. So am I taking too much of time? Do I have a time? Hello? 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 Can you hear me? Hello?
Yes, ma'am. Yes, ma'am.
Do I have a time?
No, ma'am. Another 10 minutes. Ma'am.
Okay, I'll wind up. Yeah, quickly. Yeah. Okay. I have so many slides, but I'll wind up. You can go through the slides. Okay, that's fine. Yeah. Okay. So obstetrical trauma again is a ethical dilemma. Could be delayed repairs, failure to repair, third-degree tear. As I said, OSIS. As I said earlier on. Cerebral palsy, I've already spoken, and I've given in the PPT. You can read through how it can affect and what are the how the midwife will be in dilemmas when it comes to cerebral palsy. It all comes in the first stage of labor monitoring, second stage of labor monitoring, and antenatal monitoring. So there are so many things you can actually go through it. I'm not just CTG and communication, as I said, errors in the CTG, misinterpretation of the CTG. CTG is not started when it should have been started, false reassurance with the uninterpretable trace, too slow to act on CTG identified if it's pathological, if we are not acted upon it, monitoring maternal heart rate. Always, this has happened for me back home once when we had women came into us. She had an IUD. We did the CTG, and now when I refer, but when the scan there was no fetal heart rate, but we got the CTG, and I'm very well can rely it was the mom's uterine pulse. So always check when you put a CTG when the fetal heart rate. This is again for all the nurses and midwives back home. My suggestion: please check the maternal pulse. Peripheral. CTG gives as well the maternal pulse, but check the maternal pulse. Compare the maternal pulse and the fetal heart rate. Sometimes, if you're not placed over properly, the Doppler properly, it can pick up the uterine pulse, and the maternal pulse can be picked up. So, just do a peripheral pulse. Check whether there is a difference between the fetal heart rate and the peripheral pulse. This is very important as well. So this is, I'm not going to explain. Missing notes and delays, as that I've given examples in here. What are the missing notes? If there are claims, if you're not documented properly, missing notes can come to for investigations and see, if you're not recorded, they cannot link or they cannot support, or the midwife cannot be supported if there are lack of documentation or if there are delays. So I'm just shoulder dystocia is another major problem, ethical issue. So in the shoulder dystocia, the issues always considered are whether relevant history is taken with the gestational diabetes or previous deliveries which had a big babies, duration issues arising from the first stage of labor, not, if they are not considered, if you are not considered that, duration of second stage of labor needs to be reviewed. We need to take her history. If there are big babies on anterior palpation, you would know. Sometimes the scan will show, but after 2-3 weeks of mom, baby can grow, and when you palpate, you will know whether it's appropriate gestation. If you're suspecting a big baby, you are suspecting the shoulder dystocia as well. So proper positioning, intimating the doctor, saying, say, I think this is a big baby, and if the scans when they've done it, if not, it could look like after ARM, there no fluid, there could be a suspicion of big baby. So when you're pushing, if the rotation, if the baby doesn't rotate, doesn't descend very well down, then when your shoulder delivering the shoulder, need to call one of the senior midwife. We follow the peaches here, and I think there is no time now to show all that, and I can't see because it is visual. I can't see you all. I'm unable to show that to you, which we newly come across the peaches where to prevent the perineal tears and all this where you can support. So next time maybe I could do that. So that is very, very important. Number of contractions, tractions applied, whatever, if the shoulder is suspected, what is the maneuver we have adopted, which is very, very important as well. So all this documentation is very, very important. Sometimes the obstetrician does, I know in all the obstetricians deliver, but there is always a nurse standing beside mom in the labor room, always. And they will ask, doctors just briefly describe, but they will ask the nurse, what have you observed? What have you done at the time? What did you observe? So better always nurse writes whatever the obstetrician done, what is, how many contractions were there, what maneuver they have. You don't have to explain the maneuver. Just write, did they use a maneuver for shoulder dystocia or not? What was the position used in shoulder dystocia? Was it adopted or not? Was it done or not? Please write, document, because you are also accountable for that woman when you are standing beside her. Poor note keeping, record keeping, all this I'm not going to say. I've already, said. So I'm just going to end up saying, why do error occur? We are all human. We might make a mistakes. We might get tired being long with the women or our shift. Cognitive impairments, communication difficulties, language barriers could be as well. Most of our nurses, we have a language barrier. They don't know what to write, but just write, use the medical words and just write few. Write how much you can, but do not delete, omit any documentation. What can you do to help? How can we help? to avoid all this or prevent record keeping, it should be very clear, legible, objective, date and sign, alterations clearly noted. If you've done any errors, if you've done any alterations, write like prospective notes, retrospective notes, safely stored and available. I know now here is the computer, but if you have record keeping, I think every medical hospital has a record keeping system. Records, why are they important? Essential for continuity of care. Adequate records enables will reconsider the essential parts if patient contact without reference many. Good records are vital for defending clinical negligence and claims. So practical considerations, very important. Risk assessment, communication, information, any alternatives. If not, always ask for second opinion, time, recording, documentation, any escalation of pathways. Always. I know we don't have clinical pathways. Here there are a lot of clinical pathways. So I just wanted to show how we have oxytocin safety bundle in here. And since I can't see you all, neither I have it in here. This is what my hospital has, this kind of, for PPH. If you have a PPH, this is the way we do manage and the safety medication oxytocin bundle. And so that's it. And I'm saying quality is never an accident. It is always results out of intelligent effort, according to John Ruskin. And quality means doing it right when no one is looking. I know when you are with the woman, always do right. So keep our professional rights and moral. And everybody is not excellent, but we can gain an excellence. We are what we repeatedly do. Excellence is not an act, but it becomes an habit for us, according to Aristotle. So midwifery care and dealing with ethical dilemmas or challenges. I've mentioned you so many challenges, what we can have and ethical dilemmas. In my PPTs you can, and I've given the examples which I have come across, and there are many more. There's no time, but I always say, if you want to go fast, you can go alone. But if you want to go very far, we all have to go together. It indicates teamwork. Okay, so as a team, midwifery, you can't do it alone. It is a teamwork. It's a teamwork of the midwives, teamwork of the physician, teamwork of the neonatologist. So all of us have to, do our best. So my take-home message is communication, very important. Let us be competent in our work, and let us be confident in our work and what we do. So that's it. Hello?
Hello. Thank you, ma'am.
I believe at least few of the respondents say they could hear me.
Hello, ma'am.
Yes, ma'am.
Could you hear me?
Yes, ma'am.
Yes, ma'am.
So was it clear? You have any questions? You can ask me if you have any questions.
Now I request participants to raise their questions. Dear participants, if any questions, you can clarify with the resource person now.
Are all participants logged in? Join this session.
No, ma'am. Actually, they were there. We had very good number initially. Due to some technical issue, between people, they quitted, ma'am.
Okay. Yeah. Okay.
But
yeah,
we have the good number
I can
of
see 141 number in here. Yeah.
Yes, ma'am. Yes, ma'am. Before actually it was moving more than 200. But later it became 170, but it was good only, ma'am. Thank you.
Okay.
Okay.
No. Yeah, there's a lot of... I think we should have done one trial maybe. I do not know. Because this is my third webinar from here. I've done the before and I never had any problems. So this is the first time I'm facing. I do not know. Maybe a Microsoft team. I'm not sure.
Yes, ma'am.
It was all fine.
Yeah.
I do not know, but because you can do face to face, it was like a lively, you can do face to face, you can see, and you can talk to other speakers, all those things. So I do not know. This is kind of very different. So
Yes, ma'am. Next time it will be rectified, ma'am. Sure.
yeah, I know. Any questions? Does the audience has any questions?
I think they were very clear, ma'am. Hello, Leena, there online.
I can see Leena now. Yeah.
Okay, Savita,
Yeah.
it was a very nice session, although I attended in between. I only have one question. So now we are talking about ethical dilemmas and ethical aspects, legal aspects. How different we should approach from academic point of view to handle such issues, whether it is addressed adequately, or what is your suggestion for the faculty?
Okay, as I say, because they're training the students, yeah, I spoke most of it on the practical point of view because I'm working in the practical. Because most of the ethical dilemmas are faced when you are working at the bedside more than in the education. Because when we are in the education, we teach them. I think we, as a teacher, I may not face it unless I'm going taking a patient at the bedside and then explaining or doing something along with my students. So if I'm a teacher, I'm taking my students or I'm doing something, I before I do anything, I teach the students, asking the consent, very very important, okay, with the women, whether women would like to have it. Because you see, I think we have come across in India as well. When you assign a student to a patient, they ask whether it's a staff, though we have, whether it's the student caring or staff caring. They want always a staff caring than over the students. And if there is a teacher along with them, they don't have problem. Now, when I'm here midwife, I get the medical students with me. I get the midwifery students. I get the fire brigade, all that. And before I take them, I have to ask the woman's permission. Is it okay if he or she is with me when I'm taking care of you? I have to ask before they come into the room, and they say, okay, I have no problem. Then I get them in and I introduce them. And when I train them, because they're with me with the all, and when I training them for, palpation or do an vagina examination, I always ask the woman's consent. Is it okay? She's going to be a future doctor, or is it okay? She's going to be a future midwife. Is it okay if she does, and thereafter I repeat after? Then we may say, oh, I have no problems. Then yes, we do. But similar with the it becomes again the academic as well. When we teach the student, I think we need to tell all these ethical dilemmas because they are caring in the ward. We are not there all the time with them in the ward. Now I will give the farmers example as well. Like, and I worked in postnatal ward there, and everywhere in the labor, when we assign the students, we are just assigning them, but we are not standing with them when the delivery is conducted. We are not with them at the bedside when they do a postnatal examination. We are not with them when they're giving their medications. We assign them to a staff nurses. It's always better we tell them how much ethical dilemmas are there when we are teaching them itself. I think in the theory, in the beginning itself, I remember my teachers, Sister Andrews, who did this for us when we were in the first year of fundamental of nursing, when we were studying. She always reminded this for us. I think we need to tell the students as well, these are the things, legalities or issues involved. So you always ask the woman, is it okay if I touch you before you do anything? If the teacher does, I think students follows as well. And let the teacher ask with this women as well, is it okay if the student is there with you and doing all these things for you? I think that is how we teach and train, so we can prevent. And even when they are in the labor room, we just bring them actually to there. We don't ask the women. Nobody asks when we assign the student, is it okay if the student is there when I'm doing this? We never do that. I think that is very very important part for us to do, the women to ask. Because when the incident happened in the hospital, they had blamed the student. I remember this very very well. They had blamed the student, but they blamed the student. The student did not report, you see. But student is not involved, the nurse was involved in the direct care. So I think if the student is involved, you always introduce and involve in the care and always say that and document and all those. So I think academically what I'm saying, when you are teaching, involve these ethical dilemmas, make them aware very much. When you go to the bedside, you do follow, you do take a consent, respect the women's rights, get them involved. I think they get used to it. Especially again, medication, right? I have to, when you teach the medication, giving the medication, administration medication, we do all the make the students write the medications. We never ask them to say your name, date of birth, the hospital number. We don't have that. Counter checking the medications with two people and signing them again. I don't think so. You can stop me if I'm wrong, if some of the hospitals do, and if I say no. I'm saying by my experience, what hospital I work right commonly, which is in and around in Mangalore. I do not know else. So I think this is what we need to academically teach us. We have to teach the students so students can practice. Unless when they come abroad, they practice instead.
Yes, ma'am. Thank you. And there is another question by Ms. Priscilla.
Yeah.
To solve these ethical dilemmas or to guide with ethical dilemmas, do you have any consultant in your hospital?
Yeah, no, it is, we do, yes. Like we have a clinical risk manager. As we in the hospitals, we have, even the Father Muller's has it, incident reporting, you have a quality. Similar way here, clinical risk managers you have. So whatever something clinical risk happens, you have a, for shoulder dystocia, you have form. For PPH, you have a form, clinical risk. For different incidences, which are, as I said, what are the major ethical dilemmas you can face or legal claims as kind of shoulder dystocia, cerebral palsy, neonatal or instrumental deliveries, tears. So we have a certain forms. Soon after that particular incident happened, we fill it in. So in that we write. Now, if it is a PPH, what you have done sequentially, you have it, and you have to write that, including the time, and that goes to the clinical risk department, and they analyze it. And if they check your documents, if they are not right, they get back. Because say if the woman had a PPH, and then she might happily go home discharged. She goes home, they will talk with the hundreds of friends, or they browse and they write to the hospital, or they say I had this test. They can write and claim. When they claim, or they write, or they bring, if you have specified, if hospital is ready, yes, this is incident, and hospital get ready with the documentation, what happened, hospital is ready, has a supporting documents. But if you are not documented, if you do not have any incident forms, what is it and anything, when the women writes or women claims, you have no support. Did you get me what I'm saying?
Yes, ma'am. Thank you. Yes, ma'am.
So there is a particular reporting pathways. If any incident, swab missing. I remember I came across once, the swab missed because the women went to the cesarean section. I had normal delivery, she went for cesarean section, and the swabs, for third degree tear repair to the theater, and all my instruments were here. So we count the swabs there in presence of me. We count the swabs in the theater as well. So one of the swab was missing. You know why? The doctor put the obstetrician, when she was trying to remove the cross, she put one of the swab in the glove, and the glove was in the bin. So what happened? We were counting, Enrica. We did not throw anything in. I left the room, went to the theater, came back from the theater. This girl, my colleagues had left the room because the swab was missing. They counted. I went to the theater, counted the swab, came back. Still one swab was missing after 20 swabs. One swab was missing. We took out the yellow bin, biohazard bin, took out everything, searched. We did not get it. And the obstetrician, she said, I have a habit of putting putting the swab in the glove. And she came back herself, checked in that yellow bin, put the swabs all out again, checked, and there was a swab in the glove. And the count came as a 20. And I was a midwife I had to record. Next day, the clinical came to me, and I had to record everything incident-wise, how many times it happened, how many times we checked everything. You see? So this goes. So but in case if we are not found, then you have to do an X-ray for the women, find where it is, what happened. So this is all that's why I said any clinical incidents happens, always report. I think hospitals should have, if not, our documentations are, if we do not have a certain forms in our hospitals, our documentation is a major support for us. Report, write everything in the language you know. Just write it with the time. Timing is important. Recording is very important. This happened. Report it to this is done. This is done. Just write it. Even the clinic, when they come, when you see your recording documentation, will help you support, will help them as well. So, and yes, it goes to the clinical, they arrange, and there is, if they women claim, then there is the solicitor coronal, they have that in here, managing legal ethical issues. It goes to the lawyers, solicitors, and all that. Similar way back home, it's the same procedure.
Yes, ma'am. Thank you, ma'am. So now I request Dr. Padma Priya S, HOD, Department of OBG Nursing, to deliver vote of thanks.
Thank you, Ms. Vinita D'Souza. Respected Principal, ma'am. Today, resource person, Dr. Savita, ma'am. My dear friends, and dear all participants from various institutions. Very good afternoon. It's my pleasure and privilege to propose vote of thanks and acknowledge the contributions of those who work really for the webinar a success. Firstly, I thank God Almighty for his blessings and grace. Really, with his blessings and grace only, we were able to complete today's webinar. I would like to thank our management and respected principal, ma'am, Dr. Leena Casey, for their encouragements and support. Thank you, Leena, ma'am. Next, I convey my sincere thanks to our departmental faculty, Ms. Janet Miranda, Ms. Vinita D'Souza, webinar coordinator, and Ms. Amisha Amin. Thank you all for your wonderful contributions towards this seminar. Thank you all. Though we had some technical issues, but today we all had opportunity to hear from our resource person, Dr. Savita ma'am. Really, she spent her valuable time with us. With her busy schedule, she spent her valuable time. Ma'am, thank you very much. There is no word to express our gratitudes. We are exceedingly happy to have you as a resource person here. Thank you so much, ma'am. It was very wonderful, informative session.
Hopefully you know it benefited and you got the information what you wanted to hear.
Yes, ma'am. Yes, ma'am. Of course. Sure, ma'am. I would like to thank all teaching and non-teaching faculties, IT people from Yenapoya University for their support. Last but not least, I would like to thank all participants for your patience listening. Sorry for inconvenience to everyone. Thank you so much. Have a good evening again. Thank you, one and all. Thank you.
Thank you, ma'am.
Thank you, Dr. Padma Priya ma'am. It was really a very wonderful session. Thank you, Dr. Savita ma'am, to you too.
You're welcome.
Yeah, and we are getting many messages too, ma'am, regarding the webinar, many appreciation messages too.
Yeah, I can't see you all actually. That's a very saddest part.
Yeah, so we will be winding up the session here. So now I request all the delegates to leave the session. Thank you all.
Thank you. Thanks for giving me the opportunity. Sorry
Thank
for
you,
disappointing the technical difficulties, but it
no
was
issues,
nice.
ma'am.
I'm happy to share. Yeah, thank you.
Yeah. Thank you so much, ma'am. Thank you.
Thank you.
Thank you, ma'am.